Good morning, everyone. Uh, Today's topic, opioid-induced hyperalgesia, very important topic for everyone. Those who are practicing palliative care, those who are prescribing opioids for pain management, and I think all the audience, those who have joined, I think they are prescribing opioids, and it's a very very important topic to understand and to how we will diagnose and how we will treat the patient who is having opioid-induced hyperalgesia. So, for this topic, a speaker is our senior resident, very bright and brilliant senior resident, Dr. Rabiya. She will speak about this topic, and the moderator is our own very senior faculty of the department, Dr. Seema Mishra, who is professor in the department and also chairing many multiple committees of the hospital for important decision making committees. Both of them will explain you how it is important and how to manage the per patient, what exactly it is, and how to manage the patient who is having opioid induced hyperalgesia. So, whosoever is having questions, kindly write down in the chat box. Dr. Seema will take the question one by one at the end. Okay, Rabia, go ahead.
A very good morning to one and all. Thank you, ma'am. Today I will be presenting opioid-induced hyperalgesia. I myself is Dr. Rabiya Razak, Senior Resident in MD Palliative Medicine. My presentation is moderated by Dr. Seema, ma'am. Thank you, ma'am, for moderating my presentation. So what are the contents for today's presentation? Initially, it is introduction, then the prevalence of opioid-induced hyperalgesia, the clinical presentation and the risk factors for OIH, the pathophysiology, the differential diagnosis, assessment and management strategies of OIH. Now, initially, let's look into a case scenario. A 38-year-old woman with a past medical history of a locally advanced, poorly differentiated neuroendocrine tumor involving the diaphragm, the posterior abdominal wall, right kidney, and liver presented to the emergency complaining of acute onset of abdominal pain in the epigastric region. The NRS on presentation was 10 on 10. Since diagnosis 14 months prior, her cancer had progressed despite chemotherapy. Her tumor was also deemed unsuitable for surgical resection or debulking. Her home pain management included tablet morphine CR, 240 mg Q 12 hourly, and 60 mg PRN doses as needed. Less than a month before hospitalization to this hospital, she was admitted to another hospital for pain crisis. During that admission, tablet morphine CR 120 mg BD and a PRN dose was increased to 60 mg every 4 hourly, and in time she used to take 60 mg tablet morphine every 2 hourly. After discharge, she followed up at the present hospital palliative care unit and reported significant pain despite taking her as needed medication round the clock. Now, despite reaching the target dose with some clinical improvement in pain, she continued to have severe pain crisis during hospitalization. So in this case, we have increased to opioids, but still she is in severe pain. Now let's look into a different case scenario. A 45-year-old woman, known case of CA cervix, post-chemotherapy and post-radiotherapy, presented to the emergency with complaints of severe pain in the perineal region. The NRS on presentation was 9 by 10. The pain was insidious in onset and progressive in nature. It was dull aching type of pain with no characteristic radiation noted. There was no diurnal variation. The pain was exaggerated during her maturation and not relieved by analgesics. She was on a regular follow-up in our pain clinic since the last 1 year. She had adequate pain relief with tablet morphine 10 mg 2 times 4 hourly and SOS along with adjuvants. Since last 1 month, she has been taking 1 tablet extra doses every 4 hourly. Her recent MRI report in October 22 suggests stable disease. There was no signs of any relapse or recurrence of her disease. She was admitted in the palliative care ward. Analgesic titration was being done and her pain was settled in tablet morphine, that is 60 mg 1 tab 4 hourly from 2 tabs 4 hourly. So in this case scenario, we have increased her opioid and she has adequate pain relief. Now let's keep this case scenario aside and look into what is pain. The IASP 2020 defined pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So, what do you mean by opioid induced hyperalgesia? It is defined as a state of nociceptive sensitization caused because of the opioids, that is, caused by the exposure to opioids. This state is characterized by a paradoxical response whereby a patient receiving opioids for the treatment of pain may actually become more and more sensitive to pain. Now let's look into the what is the pathophysiology of pain. Initially, there can be transduction. The nauseous chemical, mechanical, or thermal stimuli are converted into a normal action potential. Now, this action potential is conducted through the nervous system through the transmission, and it has been modulated in the dorsal horn of the spinal cord, and finally it has been perceived in the final common pathway integration of painful input into somatosensory and limbic cortex. So this is a normal physiology of how the pain is being transmitted. Now you have to know that opioids will act at different levels of the pain transmission. It can act on the transduction, in the modulation, as well as in the perception. Now let's look into the history of opioid-induced hyperalgesia. Who introduced this term? It was Albert in 1870 said that at such times I have certainly felt it a great responsibility to say that pain, which is known as an evil, is less injurious than morphia, which may be an evil. So he has compared morphine to an evil. Does morphia tend to increase the very pain it pretends to relieve? In Dr. Rosbach in 1880 stated that when dependence on opioids finally becomes an illness of itself, opposite effects like restlessness, sleep disturbance, hyperesthesia, neuralgia, and irritability become manifested. This is a comprehensive review of opioid-induced hyperalgesia by Marion Lee. He stated that opioid-induced hyperalgesia is a very distinct, it can be definable or undefinable. It is a characteristic phenomena that could explain the loss of opioid efficacy in some patients. This type of pain experience might be same as the underlying pain or might be completely different from the original underlying pain. Now let's look into the clinical prevalence. How prevalent is opioid-induced hyperalgesia in our day-to-day practice? Now, this is a review article by opioid-induced hyperalgesia, a research phenomenon or a clinical reality. Now, Grayson et al. In 2020 stated that the prevalence of opioid-induced hyperalgesia using average number of patients treated per year with opioids was 0.002% for acute pain and 0.01% for chronic pain. 462 patients were being treated in that year. Now, what is the risk of developing opioid-induced hyperalgesia? The first and the foremost is the patients who were chronic opioid addicts and who are right now in methadone maintenance therapy. Second, it can be because of perioperative analgesia. The patients who have received opioids during their perioperative period. Maybe it may be a short time or a long-term exposure. Healthy volunteers who are being exposed to opioids. And chronic exposure to opioids are the most important risk factors for development of opioid-induced hyperalgesia. Marion Lee, in his comprehensive review of opioid-induced hyperalgesia, have stated all these risk factors of development of opioid-induced hyperalgesia. Now let's look into each and every risk factors in detail. Methadone maintenance therapy. In former opioid addicts who are on methadone maintenance therapy, there is some evidence to support that they can have a risk of development of opioid-induced hyperalgesia. Many studies have been done comparing patients who are on methadone maintenance for history of drug abuse have demonstrated patient population has increased pain sensitivity as accessed with a cold press test as compared to the healthy matched controlled subjects. Now, this was stated in the opioid-induced hyperalgesia in a cancer patient on high-dose methadone maintenance therapy, a case for subspecialty opioid use disorder by EZA in 2020. In this case report illustrates the current challenges how the healthcare providers encounter when treating patients on chronic medication-assisted treatment for non-opioid related conditions. Now, opioids in perioperative period. Two prospective studies have showed that patients on a high dose of opioids intraoperatively had increased pain scores along with increased postoperative use of opioids. A randomized study was being done with 60 patients undergoing abdominal hysterectomy. One group of people were given a low dose of fentanyl at induction of anesthesia, and another group of people were given high dose of fentanyl bolus at induction of anesthesia. It was noted that the patients in a high dose group had higher pain intensity scores post-operatively while consuming more opioids as compared to the low dose fentanyl group. Now, this was quoted in this Leslie, a review of opioid-induced tolerance and hyperalgesia in the year 2019. Does perioperative opioid analgesia when is enough too much? Now, looking into the healthy volunteers on opioid therapy, models of secondary hyperalgesia and cold pressure induced pain included healthy human volunteers when given opioids given on a short term basis, may be at a risk of development of opioid induced hyperalgesia. So, even at a short term basis, they have an increased risk of developing OIH. A double blind randomized crossover and placebo controlled design in opioid naive healthy human volunteers to test whether hyperalgesia would develop within 30 minutes of stopping an infusion with remifentanil. The study reported that in volunteers, a skin area with pre-existing mechanical hyperalgesia was significantly enlarged after the remifentanil infusion was stopped. So this study was taken from a double-blinded randomized crossover trial by Eckward in the year 2016. He concluded that a higher dose of fentanyl led to significantly decreased pain scores as measured by a numerical rating scale, but increased areas of hyperalgesia from 4.5 to 6.5 hours after fentanyl administration. Now, very high or very low dose of opioids. Ultra high doses of opioids can produce allodynia and possibly hyperalgesia. The allodinic or hyperalgesic state is not reversed by any opioid antagonist and can be aggravated when the dose of the causative opioid agonist is further escalated or it can be de-escalated. The dose reduction of the causative agent or a substitution with an opioid agonist is always a key to prevent OIH. Yash et al. In 2016 suggested that you can switch. If there is opioid-induced hyperalgesia, you can switch from a phenanthrine morphine to a piperidine derivative, that is fentanyl or sufentanil, is a valid strategy to prevent the development of opioid-induced hyperalgesia. Now, chronic exposure to opioids. A systemic review and meta-analysis by C. Higgins in the year 2018 suggested that opioid-induced hyperalgesia was more evident in patients with opioid use disorders than in patients with pain, and the patients who have been treated by NMDA antagonist. So we have looked upon all the risk factors. Now, how will the patient present to us the clinical presentation of opioid-induced hyperalgesia? The first and the foremost, you keep increasing the opioid dose, the patient will have severe pain crisis. There is no relief of pain. The first and the foremost indication of opioid-induced hyperalgesia, that is declining levels of analgesia while receiving opioids. There is worsening pain syndrome, experience of excessive pain after surgical procedure. Increasing opioid does make the pain worse. The pain intensity is usually very undefinable, it is very diffuse, it keeps on fluctuating. Most time the area of pain is very much hyperalgesic. Reducing and tapering down the opioid medication will make the pain better. So now let's look into the pathophysiology of opioid-induced hyperalgesia. There are different mechanisms listed for pathophysiology. The first and the foremost, which is more having an important role, is the central glutaminergic system. Second, you have the spinal dynorphin. Third, you have the descending facilitation. Fourth, any genetic influences. 5, decreased reuptake and enhanced nociceptive response. Other mechanisms which have been stated is the peripheral effects, the central effects, and the supraspinal effects. Now let's look into the detail of each one. I have taken this pathophysiology from this review article, Laurie and Rackle, opioid-induced hyperalgesia, cellular and molecular mechanism. Now let's look into it in detail. Now, what is the central glutaminergic system? It plays the central role in the development of opioid-induced hyperalgesia. Acute as well as chronic opioid use will increase the NMDA receptor activity. Mao et al. In 2016 have shown that prolonged morphine administration includes the downregulation of all these spinal glutamate transporters in the spinal cord, leading to an increased glutamate levels. The glutamate associated activation of the NMDA receptors can cause spinal neuron sensitization, possibly contributing to the development of OIH. This phenomenon has been prevented by the NMDA receptor inhibition. For more clarity, this schematic diagram has been represented. So you have been giving acute opioid or chronic opioid exposure. It will activate the NMDA receptor, so there is more and more influx of the calcium, causing the depolarization. Now, these NMDA activity will start down-regulating all the glutamate transporters. Now, once the glutamate transporters are down-regulated, all the glutamate is available. So more and more glutamate is available in the presynaptic region, and these glutamate will still keep on activating the NMDA receptor. So this is called as a glutamate associated NMDA receptor activation. Now this in turn will lead to the release of substance P, bradykinin, prostaglandins, histamine, and substance P, serotonin, which will cause hyperalgesia. So it is called as a glutamine associated NMDA activation leading to spinal neuron sensitization leading to hyperalgesia. So this is the most important mechanism which has been postulated in OIH. The spinal dynorphin. Now what are dynorphins? The dynorphins are opioid peptides which have been shown to increase with continuous infusion of mu receptor agonist. These increased levels of dynorphins lead to the release of excitatory neuropeptides like the CGRP and the CCK. Now, these excitatory neuropeptides act as a pro-nociceptive agents that enhances the nociceptive input at the spinal level. The third mechanism proposed is the descending facilitation. Now, sensitization of the primary efferent neuron will lead to release of excitatory neurotransmitters. There is sensitization of the second order neurons, and these all causes the neuroplastic changes in the rostral ventromedial medulla that may increase the facilitation of the on cells, leading to the upregulation of the spinal dynorphin and enhanced primary efferent neurotransmitter release as well as pain. So this is a schematic diagram for more clarity. So initially there is plasticity in the RVM initiates bilateral tonic descending facilitation via the DLF. The descending facilitation upregulates all the spinal dynorphin, which are the opioid peptides. Now these non-opioid actions on the spinal dynorphin will activate or enhances the primary efferent transmitter release as well as pain. So this enhanced efferent transmission increases the pain signal leading to hyperalgesia. Now, the fourth mechanism proposed is the genetic influences. There is a change in the genetic makeup. That is, the chronic exposure to opioids may alter the G protein activity, such as the G protein second messenger systems are converted from an inhibitory to an excitatory coupled mode, because there is some alteration in the glycolipid complex on the neuronal cell membrane. This increase in excitatory activity has emerged as a possible contributor to analgesic tolerance as well as opioid-induced hyperalgesia. In vitro studies have demonstrated that when opioids are combined with ultra-low doses of an opioid antagonist, excitatory effects can be blocked. Now, it can be either because of the increased release of nociceptive response or decreased uptake. So, whenever there is an activation of the NMDA receptor channel, there is release of all the pro-nociceptive peptides. Now, the pro-nociceptive response is delayed or masked by analgesia, but after repeated administration, there is increase in the excitatory release and increase in the pro-nociceptive peptides leading to hyperalgesia or allodynia. The other mechanisms involved in opioid-induced hyperalgesia is the central sensitization. So whenever you have a nociceptive event, any injury or mechanical, thermal or chemical injury, what happens is there can be changes in the NMDR and AMPR receptors. There can be changes in the AMP receptors into the membrane. There can be changes in the ion channel, the sodium, potassium, calcium channels. There can be reduction in the activity of the GABA and the glycine, which are the inhibitory neuropeptides. And the cellular process, there is increase in the membrane excitability, synaptic facilitation, as well as disinhibition. The development or increase in spontaneous activity, there can be a reduction in the threshold for activation by peripheral stimuli and enlargement of their respective fields. So this can lead to central sensitization leading to hyperalgesia and allodynia. Now looking into the peripheral sensitization, Now, because of persistent nociceptive efferent activity, the initial trauma, there is inflammation and peripheral sensitization. There is increased release of interleukin 1, interleukin 2, 6, TNF, CGRP, bradykinin, and substance P. So, this local injury causes the primary efferent fibers in the traumatized area to be more sensitive to nauseous stimuli. These keep on releasing the bradykinin and substance P. This increased firing can lead to hyperalgesia as well as allodynia. Now, there are some effects called as supraspinal effects above the spinal cord level. Now, these supraspinal effects will facilitate more and more release of substance P, glutamate, and serotonin, leading to hyperexcitability and hyperalgesia. So, this was all about the pathophysiology of opioid-induced hyperalgesia. Now, let's look into a similar term, that is opioid tolerance. It is very difficult to differentiate between opioid-induced hyperalgesia and tolerance. This is a little bit confusing part. So, let's look at what is opioid tolerance. The tolerance is a physiological response, whereas opioid-induced hyperalgesia was a pathological process. Now, in this opioid tolerance, where the body adjusts to a medication that is frequently present, usually requiring a higher doses of the same medication over time to achieve the desired effect. The common occurrence is in individuals taking a high dose of opioids for extended period of time and does not predict any relationship to misuse or addiction. So now this is the G protein and beta arrestin mediated MOPR signaling pathways. Usually, in acute opioid treatment, the opioid gets attached to the opioid receptor, G protein coupled receptor. There is potassium influx, calcium influx, adenine cyclase. There is activation of the G protein coupled receptor, leading to downstream signaling and analgesic effect. But if you're giving acute opioid treatment, some of the receptors may get desensitized because of the beta arrestin pathway. So these G protein coupled receptors can get internalized into storing vesicles, and then there is recycling. So there is a reduced downstream signaling, leading to tolerance and insufficient analgesia. So you have to keep on increasing the opioid dose for the same receptor to get activated and have adequate analgesic effects. It has seen in chronic opioid use, what happens is that all the receptors are downregulated because of the beta arrestin pathway. There is degradation of the receptors, so there is no receptors for the opioids to get binded. So this can lead to hyperalgesia. Now, this is a good table how we will differentiate opioid-induced hyperalgesia and tolerance. In opioid-induced hyperalgesia, you cannot be overcome by increasing the dosage. How much ever opioids are being increased, the pain will keep on worsening. It is a form of pain sensitization, like the peripheral sensitization or the central sensitization. The pain is worsened with increasing the opioid dosing, which is very important. The pain can be improved if you reduce the opioid dose to 25 to 30%. Opioid-induced hyperalgesia occurs at a certain critical opioid dose, may be lower in patients with renal dysfunction. It is often overlooked as a potential complication of opioid therapy. We will be discussing a few of the terminologies which are very related to each other. The first is the opioid tolerance. In opioid tolerance, the nature of the pain, whenever you have an injury, it is localized to the site of pain. And the onset is very gradual. It happens over the course of time. And if you give opioids in this patient, the pain actually improves in opioid tolerance. And the type of previous opioid use is either, mostly it is long-acting opioids, like this continuous release, CR. In opioid withdrawal, the pain is usually diffuse and hyperalgesic. It is not localized to a particular site. And the onset is very abrupt. You withdraw the opioids, and within 24 to 48 hours, the patient will start having symptoms. The pain improves again with opioid administration, and the type of previous opioid use is a short-acting opioid. Now, the topic which we are discussing today is the opioid-induced hyperalgesia. The nature of the pain, again, it is undefinable, it is diffuse, hyperalgesic areas. The onset can be abrupt as well as gradual onset. And if you give opioid, the pain will keep on worsening. So there is worsening pain syndrome with opioids. And the type of previous opioid use, it is usually short-acting. Now, coming to pseudo addiction is localized to the pain site. The onset can be ongoing. The pain may improve with opioid administration, and it can be either. It can be long acting as well as short acting. Now, coming to the addictive disease, it is diffuse hyperalgesia. The pain is keep ongoing. The pain also worsens with opioid administration, and type of previous opioid used is usually short acting. Now, this is a schematic diagram showing tolerance, dependence, and withdrawal. Normally, only a small number of opioid receptors are activated. But if you're giving opioids for a longer period of time at a larger dose, what happens is all these receptors become overactivated. All the receptors getting overactivated. The body will start restoring it into storage vesicles inside the vesicles. So in opioid tolerance and opioid dependence, what happens is with few receptors left, only few receptors are present, the dose of the opioid, only few receptors will be activated. So the few receptors also require continuous opioid to maintain their activity. So more and more opioids are required to have the same analgesic effect. In opioid withdrawal, what happens? The few receptors which are already present are also turned off. This can cause withdrawal symptoms. So we have explained about the risk factors of developing OIH, what is the clinical features, what is the pathophysiology. Now let's look how to diagnose opioid-induced hyperalgesia. Now, Akian, in his review article of opioid-induced hyperalgesia, stated that there are no exact mechanisms or clinical tests to diagnose opioid-induced hyperalgesia. It is a clinical diagnosis. One of the tests which has been proposed in the study is quantitative sensory testing. It is a pain assessment tool. It involves the application of different mechanical thermal stimuli of controlled intensity to measure an individual's pain threshold. The testing accesses the functioning of A beta, A delta, and C nerve fibers and also the central pain processing pathways. So, in opioid induced hyperalgesia, reduces pain tolerance, enhance sensitivity to cold pressure stimuli in QST testing. So, this is a schematic diagram showing how the QST is being using cold pain, heat pain, and mechanical pain. In hyperalgesia, they are more sensitive to cold pain pressure tests. Now we know how the diagnosis of OIH, it is mostly clinical. You can use the quantitative sensory testing. Now management strategies. Now how to manage OIH? The first and the foremost is how can we prevent OIH? You have some pharmacotherapy, you have interventional therapy, you have psychological therapy. Now, once the OIH has occurred, how do you manage the symptoms? You can either go for dose reduction or you can go for opioid rotation. NMDA receptor antagonist is available like ketamine, dextromethorphan, and other drugs like propofol, COX-2 inhibitors, alpha-2 receptor agonist. Now, how do you prevent the development of OIH in clinical practice? The pharmacotherapy, you have anticonvulsants like gabapentin, pregabalin, you have antidepressants like SNRIs and SSRIs, you have NSAIDs. Now, these opioid sparing therapies form the basis of preventing opioid-related adverse effects. So this is a table showing how you can start gabapentin and pregabalin. You can always start at an 300 mg HS dose. You can increase it into BD doses over the course of 1 week. The maximum recommended dose is 3600 mg. Now, pregabalin, you can start 75 mg twice a day, and the maximum dose per day is 600 mg. Now, this is a schematic diagram showing the importance of adding an adjuvant with opioids. Normally, if you give an analgesia, there are low levels of alpha-2 delta-1 NMDA receptor activation. There is normal pain sensitivity. If you're giving chronic morphine, now what happens? There is increased activity of the NMDA receptors, which will lead to hyperalgesia and analgesic tolerance. But if you add a adjuvant like a gabapentin anticonvulsant, there is again a normal activity NMDA receptor interaction leading to normal pain sensitivity. So it is always advisable to add an adjuvant along with morphine in order to prevent opioid-induced hyperalgesia. Now you have different multimodal analgesia like NSAIDs, which will help in reducing the production of excitatory amino acid neurotransmitters, which will aggravate the pro-nociceptive actions. Now, progressively and rapidly reduce the dose of casual opioid to 25% of peak dose. So, if you're adding an adjuvant, you can actually reduce the dose of opioids by 25%. Now, there are few interventional therapies which can help in reducing or preventing opioid-induced hyperalgesia, like regional anesthesia, spinal anesthesia, some blocks like ganglionimpar block. It can be celiac plexus block. You have also spinal cord stimulators. Now, these spinal cord stimulators will keep releasing some tingling sensation and will try to mask the actual pain sensation. So, these can be few of the interventional therapy you can consider for preventing opioid-induced hyperalgesia. Now, psychological therapy. So, what do you mean by cognitive behavioral therapy? It will affect your thoughts, it will create feelings, your feelings will create a behavior, and your behavior will create thoughts. So, multiple sessions of CBT will be helpful in preventing opioid induced hyperalgesia. It will make the patient feel less stressed, he will be able to manage, improved mood, helpful thoughts, and relaxation techniques will be advised. And throughout the treatment, you have to always have support, counsel the patient throughout the opioid induced hyperalgesia episodes. Now, how do you manage the symptoms once already the OIH has occurred? Now, here comes the opioid switching. Now, methadone is a weak NMDA receptor antagonist, so you are trying to block the NMDA receptor activity. Now, due to this property, many case reports have shown that clinicians choose to switch patients to methadone when OIH is suspected. So, opioid rotation to methadone significantly improved or resolved suspected OIH. Now, switching to an opioid with a less risk of OIH, that is fentanyl to morphine, methadone, or buprenorphine. Switching from morphine because of several neural hyperexcitability, lower than expected dose of alternative opioid is likely to be needed unless the dose of morphine has been much reduced. Now, what if OIH still is not resolved even after switching the opioid? You can again go for interventional therapies like spinal or regional or local analgesia. You can also check for the magnesium levels in the blood, which can aggravate OIH by attaching to the NMDA receptor. It blocks the NMDA receptor, leading to NMDA associated glutamate associated NMDA receptor activation. The ketamine and methadone have also been shown to attenuate OIH. Now, NMDA receptor antagonist. Now, what is an NMDA receptor modulation drug? An NMDA receptor has several subunits. You have the NR1, NR2, NR3. They're differently expressed in various regions of the brain during the development. The subunit expression of individual NMDA receptors can affect their binding sensitivity to neuromodulators and function. Alternate splicing of these subunits further diversifies the receptor expression. There are a lot of varied and ubiquitous expression of NMDA receptors throughout the CNS can create challenges in targeting the pathological activation of NMDA receptors while still permitting normal physiological activation to occur. So this is a schematic diagram showing what are the different subunits, how the calcium influx and sodium and potassium efflux takes place. So this is an NMDA receptor. So what are the NMDA receptor agonist drugs we have? First and the foremost is the ketamine. It can be given as IM 2 to 4 mg per kg. The CNS effects include hallucination, confusion, dreamlike state, irrational behavior. Other effects like respiratory depression, increased CSF pressure, hypertension, tachycardia, tremor, nystagmus, and myocardial depression. It is always recommended to give a benzodiazepine along with ketamine to prevent the hallucination and dreamlike states. Methadone, the oral dose of methadone is 2.5 to 10 mg q 8 to 12 hourly. It can also have side effects like CNS depression, respiratory depression, QTC prolongation, constipation, nausea, vomiting, dizziness, and disorientation. You have memantine, which is the per oral dose is 10 to 30 mg per day, leading to hypertension, dizziness, drowsiness, confusion, anxiety, and hallucinations. Amantadine is IV, 200 mg infused over 3 hours. The per oral dose is 100 to 200 mg per day. It can lead to orthostatic hypotension, dry mouth, drowsiness, agitation, confusion, hallucination, and dyskinesia. Now, dextromethorphan is again a weak NMDA receptor antagonist. The per oral dose is 45 to 400 mg per day. The side effects like lightheadedness, drowsiness, confusion, nervousness, visual disturbances, and serotonin syndrome. Now, coming to ketamine. Ketamine is an uncompetitive antagonist of the cyclidine binding site of the NMDA receptor. A lot of meta-analysis study was being done, and it was seen that the perioperative ketamine did reduce post-operative opioid consumption by 30%, but did not reduce the opioid-associated side effects except nausea and vomiting. Now, this review article by Clayton Klump, Ketamine Used for Cancer and Chronic Pain Management, stated that perioperative administration of a low dose of ketamine may modulate the expression of OIH or analgesic tolerance, and that it reduces the postoperative wound hyperalgesia after acute intraoperative opioid exposure. So, low dose of ketamine can help prevent the OIH symptoms. Now, coming to dextromethorphan, it is again a non-competitive NMDA receptor antagonist which is used as a cough suppressant. Now, Galler et al., in a randomized double-blinded placebo-controlled trial in the year 2004, said that three multicenter randomized double-blind controlled clinical trials failed to demonstrate enhanced opioid analgesia or reduction in tolerance. Now, there are some other drugs like recent evidence suggests like propofol may have some modulatory effect on OIH, possibly through its interaction through alpha aminobutyric acid receptors at the supraspinal level. So we have completed the management strategies of opioid-induced hyperalgesia. Now let's discuss the case scenario which we had presented in the initial first two slides. Now I'll be repeating the case scenario. A 38-year-old woman with past medical history of locally advanced, poorly differentiated neuroendocrine tumor presented to the ED with NRS of 10 on 10, abdominal pain in the epigastric area. Since diagnosis 14 months prior, her cancer had progressed despite chemotherapy. Her tumor was also deemed unsuitable for surgical resection. She was given tablet morphine CR 240 mg Q 12 hourly and 60 mg PRN doses. On admission, her morphine CR 120 mg was given PD, and her PRN doses were increased to 60 mg 4 hourly, and at times she was taking it every 2 hourly. Even after increasing her morphine dose, she still had severe pain crisis. Now let's evaluate this case. So she had uncontrolled pain. First of all, you have to rule out any progression of the disease. If there is no progression of disease, and if it is yes, progression of disease. If there is a progression of disease, you can proceed according to the underlying disease. If there is, maybe it can be a disease progression, relapse, recurrence, and you can think about giving chemotherapy, radiotherapy, or surgical intervention. If it is no, there is no progression of any underlying disease, you have to think about tolerance. Isn't the same amount of opioid giving her the same relief? Or does she require more opioids will give her the adequate relief? So slowly increase the increase the opioid dose along with multimodal analgesia. So increasing the opioid dose in this patient, we have already increased. We have increased the PRN doses. If there is improvement, continue the same treatment. But in this patient, there was no improvement. We kept increasing the opioid dose. She was coming with pain crisis every now and then, and she required hospitalization. So opioid is actually worsening her pain symptoms. So this is an indication of opioid-induced hyperalgesia. Now, this is an original case study which was been published in 2018 in the Journal of Pain and Palliative Care Pharmacotherapy by Andrew Wilford. In this case study, this patient was given a low dose of ketamine infusion. It was seen that low dose of ketamine infusion in high opioid requirement patients secondary to pain from a poorly differentiated neuroendocrine tumor, the infusion ultimately allowed reduction of her opioid dose to 1/3 of her original daily requirement and improved her function and ability to interact for several days. So now let's look into the second case scenario, which we've been earlier you said. A 45-year-old woman, known case of sear cervix, post-chemotherapy, post-radiotherapy, presented to the ED with complaints of severe pain in the perineal region. NRS was 9 on 10. The pain was insidious in onset and progressive in nature, dull aching, no diurnal variation, aggravated micturition, and not relieved by analgesics. She was on regular follow-up in the pain clinic, and she had adequate pain relief with tablet morphine 10 mg 2 times 4 hourly. But since the last 1 month, she had severe pain, and the pain was not resolving with the same adequate amount of morphine. Her recent MRI report also suggests that there was a stable disease. There was no evidence of any relapse or recurrence. She was admitted in the palliative care ward, analgesic titration was being done, and her pain was completely settled with tab morphine, 60 mg, 1 tab, 4 hourly, and SOS dose. So let's look into this case. She had uncontrolled pain, rule out of progression of disease was being done. So there was no progression of disease, and we increased the opioid dose slowly, and she had improvement in pain. So this is a case of tolerance. As we increased the dose of opioids and multimodal analgesia was added, she had adequate pain relief. So this is a case of opioid-induced tolerance. She required increased amount of opioid to have the same desired effect. So increasing the opioid dose of opioids did relieve the pain. So this is a case of opioid tolerance. So in summary, I would like to say that first, whenever a patient is presenting to your clinic or OPD or inpatient, increase the opioid dose and evaluate for tolerance. If the increase in opioid dose is giving her adequate pain relief with no disease progression, it is a case of opioid tolerance and it is a normal physiological process. Second, reduce or discontinue the opioid and then evaluate. Does reducing the opioids actually improve the pain? Consider opioid rotation, for example, fentanyl, buprenorphine, or methadone. Always, it is recommended to add an opioid sparing drug like the NMDA receptor antagonist, ketamine, or opioid sparing medication like antidepressants or anticonvulsants or NSAIDs. And always, in any step, you can always consider non pharmacological intervention like physical therapies, local anesthesia, regional anesthesia, spinal anesthesia, or even the spinal cord stimulators. Thank you.
Thank you, Rabiya, for the wonderful sessions. Do you have any questions from the audience? Anyone wants to ask? This was a difficult topic as together, and Dr. Rabiya has tried to simplify as much as possible. Or anyone wants to share their experience in day-to-day activity, they found any time they had a confusion regarding any opioid tolerance or opioid-induced hyperalgesia. So we can discuss it. Dr.
Thank
Shubha,
you.
whether you like to, Dr. Nandini,
Thank you, Dr. Seema.
yeah.
And this presentation was, much needed. We know very little about it, and there is a lot of evidence, and she presented it very, very clearly. Every topic seems to have so much. I mean, I don't know how to complete all the, how do we update ourselves on everything that is going on in the field, but it is so nice that these lectures are giving us a sort of a, prepared capsule of everything. Thank you so much for this topic. And one thing I wanted to emphasize is the psychological component, which is sometimes, it is not the pharmacology that needs to be manipulated. Sometimes as we continue communications, the patients start responding also. So I think Dr. Robert Wycross has put it in his introduction to palliative care, one example where so much of morphine could be brought down and the escalating morphine was not effective. So that engaging psychologically and completing the communication gaps is a very important step prior to labeling the patient as a, hyperalgesia to opioids. Thank you.
Dr. Nandini very well said that for any pain patients where we requirement, we start from that any assessment, that one of the important assessment is a psychological assessment in when we are managing pain part. So when we are assessing pain part, psychological assessment is important, and simultaneously that management part, it is equally important. So comprehensive management is that starts with the psychological component itself. So without labeling any patient opioid tolerance and opioid-induced hyperalgesia, which is very well difficult to really diagnose it, the psychological component has to be taken care of it. That's very well said. Anyone wants to add anything? Dr. Shobha, very well like to comment upon it?
Yeah, good morning, Seema. Thank you. It was a wonderful presentation, and the way she presented, there was continuous flow without any breaks. and her diction was superb, and it was very, very clear. So, and the slides were very clear, and the thought process also. So, thanks to you too. I just wanted to add a point. When we talk about the opioid tolerance, so that means that the patient has a chance of getting addicted to, opioids, because recently we saw a patient who's had CA lung for the past 4 years, and he's been on morphine. And suddenly someone stopped his morphine when he went to another hospital. He had morphine from a different hospital, and someone else stopped it from another hospital, and he came with uh, apparently withdrawal symptoms and things like that. But I'm just saying this as an anecdote. But when people are getting addicted, and we are not sure whether this is addiction or hyperalgesia and things like that, so one thing that can bring down the withdrawal effect is clonidine, which is an alpha-2 agonist, and we can start it as a small dose in the night, as an HS dose, and then see like what their blood pressure is. Of course, at the end of the day, it's an antihypertensive, but basically used for pain management extensively by anesthetists in their epidural infusions, etc. So it is a very good drug to have in our armory. We can start it as an HS dose and then probably increase it to 3 times a day. I'm not whether that is going to help with the hyperalgesia bit. That is something which we can do as a collective research, maybe. When people are having this pain, and like a presenter said, we reduce and see whether the pain comes down, and that if that can take care of the pain. And sometimes we feel that dose needs to be maintained for something else, but we need to bring the pain down. I don't know whether addition of clonidine can do that. So it is a very good drug to have. So maybe we can read up more on it and be up to mark with that too. Thank you.
Thank you, Dr. Shobha, for commenting on the chlorine. Though personally, I don't have much experience of using chlorine. Only for the study, we have done a project in that we have used it, but only the drawback that time we felt that patients are having the hypotension the much more, and that was difficult to really treat it. But it is a really adjuvant drug which you can use it. But over the years, more than 2 decades, we are using it, we managing the cancer patient, and we always have found that whenever the dose requirement is increasing frequently, and I think the role of intervention is much more coming in the practice. Though initially we have only the opiates and opiates, the intervention and that intervention any form, since we are being anesthetist, we are lucky that we have experience skills of using that intervention parts. So we feel that even those are non-anesthetists, they are managing the pain part, and when they feel that patient are requiring the opiates in the higher dose, they should really explore regarding the intervention, and they can send the patient, if they don't have facility to their own center, they can really ask the patient to go and where the intervention can be done. The skill is required for the intervention, and the requirement of the opiates has to be decreased, and chances of such type of those side effects, or you can say we can have a lesser number. And over that the dose of opiates, even the side effects like nausea, vomiting, constipation, some is very, very much bothered about it. We can really overcome the side effects in the using the intervention part. Anyone else wants to comment on anyone? Any junior residents, they can want to share where they found that they're finding the difficulty really how to diagnose tolerance, or they feel that is there in this term is there. Anyone? I'm not able to see the names of the JRs, but I can only see the names of my department JRs. If they want to ask anything, they can ask us or Dr. Rabiya. Still, we have some time to discuss it. Dr. Pratasha, you want to ask anything? Your exam going student? Dr. Rabiya, she has really presented very well. Still, you have any question in your mind, you can ask. Alice,
Good morning, ma'am.
Yes.
Ma'am, I was thinking whether it was if there was any way to distinguish the refractory pain from opioid tolerance. Because we had a patient in NCI, I don't clearly remember, maybe like 3 or 4 months back, maybe 6 months back. He was, I think, case of CA prostate. He had pain in the right lower limb and upper back. We gave him like almost everything we had. In fact, we even started him on morphine first, but because of high dose, we rotated to fentanyl. But then we gave him lignocaine infusion even, but we had to stop it because of his burning sensation by the lower limb. Then we gave him interventional analgesia. I think we gave him intraspinal epidural, yeah, epidural. It was partially managed, but still the patient was in pain, and he was under evaluation only. So we were like in a dilemma how to proceed in that case.
So, unless one thing is very sure, whenever that underlying that disease progression, when you go, if you go back and just trying to remember the figure which Rabiya, she has tried to show that how to distinguish from the tolerance and opioid induced hyperalgesia. So before leaving the patient to the tolerance, one thing is very sure that we have to see that progression of the disease. Okay. Then refractory pain, one of the component can be a tolerance, but when in tolerance will increase the doses of opioids, definitely there will be a relief in the pain. But refractory pain, those where there's a complexity, that progression of the disease is there, where you require multiple drugs. Okay. So in that case, if that multiple drugs are going to be required, we cannot label that patient is having a tolerance.
Yes, ma'am.
So opioid tolerance is going to be that patient's tolerance, if patient has adjusted, body has really adjusted to that particular dose. And when we increase the doses of opioids, you can also try to remember the figure which she has shown where the opioid receptors are there and how that in the tolerance, what has really happened to the opioid receptors. Okay. So in that figure, if you remember, you will be able to really analyze that how we can label the tolerance. And in the clinical setting, either advanced disease or the progression of the disease, definitely we are going to use multiple drugs and it has a refractory component, no doubt about it. And we one by one, we have to change that. Either we can change the drug, either we can do that intervention, some form the intervention, which we all already done it. And other drugs, adjuvant other drugs also we can use it.
Thank you, ma'am. Thank you.
Anyone else wants to ask any questions? Still we have some time. Otherwise, we'd like to wind up. Dr. Kalpana, whether we like to comment on anything, Dr. Kalpana? I think she's not there. Dr. Paneet, you want to ask anything or you want to have any comment? Dr. Paneet.
Good morning, madam. I was really impressed by the presentation. Thank you. Just wanted to ask any experience with oral clonidine, which in our setup, did we start using oral clonidine for
that you
managing?
you can try since we are also not having much experience of it, but definitely in our anesthesia practice, we some other cases we are using it any form. And for
in the refractory cancer pain, ma'am.
Yes, in that case, from my side, I don't have much experience of it. But definitely when we go in the literature, it just shows that in adjuvant drugs, we can use it. And Dr. Shobha, she is really elaborating in that use of clonidine. So I think we can try.
Thank you. Thank you.
So if there are no comments, we can stop here, Seema.
Yeah, ma'am.
So I just want to add 2 points that there is a lot of research required in this area, like role of clonidine, oral clonidine. And there is second point is we should not forget the role of non-pharmacological therapy. Non-pharmacological therapy really works well in all these patients. As Nandini said, psychological therapy and non. So whenever you are finding very, very difficult to treat intractable cancer pain patients, and if you are going, your diagnosis is going towards probably opioid induced hyperalgesia or any intractable neuropathic pain or intractable pain, don't forget the role of psychological as well as non-pharmacological therapy. So it was a wonderful presentation, Ravia. Very tough topic. Systematically, you have presented a lot of good things. And thank you very much. Thank you, Seema, for moderating so beautifully well. And thank you everyone for joining. Lot of good this thing comments are there. Archana, you can forward it to Rabia so that she will feel good appreciation comments. Okay, and thank you everyone. We'll see you next week before 6:30 for the next important topic. So no, don't miss whosoever is 73 people are remaining. So you should pass on this message that now the topics are very, very important topics, rarely discussed topics. So they should not miss all these classes. And these classes are very important, especially for PGs and newly joined palliative care physician, as well as the senior people, those who we hardly get time to search the literature, and everything is happening in 1 hour. So please join these classes. Thank you very much. See you next week before 6:30. Thank you, Seema. Thank you, Rabia and Nisha and Archana. And thank you, everyone.